Hi everybody, today I'll be discussing the liver function test. The liver is an amazing organ which performs a number of functions. Now the major functions of the liver can be grouped as excretion and secretion, its function in carrying out various metabolic processes, its function in bringing about detoxification, and its function of storage. Now the liver function tests are used to assess whether the liver is carrying out its functions normally or not. It can be classified based on tests for excretory function, test on its role of detoxification, test to assess its synthetic function, test to assess its metabolic function, and the liver enzymes. Now all the tests need not be performed in every case and is selected as per the clinical symptoms and signs. Now first let us look at the first type of test that we can do, that is the test based on excretory function. The liver is capable of removing toxic endogenous and exogenous substances from the blood. And the test based on excretory function is related to bilirubin metabolism. As you know, bilirubin is the end product of heme catabolism. So what happens to heme or hemoglobin? First, the heme part is split from the globin part. The heme is then degraded to biliverdin, and then by the action of the enzyme biliverdin reductase, it is converted to bilirubin. Now what happens to this bilirubin? Bilirubin, as you know, is insoluble in water, so it is carried or transported to the liver bound to albumin. Once it reaches the liver, it gets conjugated and first forms bilirubin monoglucuronate and then further bilirubin diglucuronate. This conjugated bilirubin is now soluble in water and it can then be passed on through the bile. It can go to the intestine. In this intestine, it can be converted to stercobilinogen and stercobilin, which is then excreted in the feces. Some of it is then carried through the enterohepatic circulation and it goes back to the liver, and from the liver it is then passed on to the kidney and excreted. In the kidney, it can get converted to urobilinogen and urobilin, in which form it gets excreted out in the urine. Now let's look at the tests which are used to assess the excretory function. So the test which involves bilirubin involves both the serum bilirubin and the urine bilirubin. So there are 5 different types of tests that we can do. We can estimate the levels of serum bilirubin, urine and fecal urobilinogen, the urine bile salts, and the dye excretion test. Now, in a normal individual, the total bilirubin which is present in blood is between 0.2 to 0.8 milligram per deciliter. It is usually less than 1 milligram per deciliter. Now, as I told you, bilirubin can be of 2 types. There can be conjugated bilirubin. The normal level is between 0.1 to 0.4 milligram per deciliter, and unconjugated bilirubin, which is between 0.2 to 0.7 milligram per deciliter. The conjugated bilirubin is soluble in water and so it is excreted by the kidney, whereas the unconjugated bilirubin is insoluble in water and it's bound to albumin for it to be transported to the liver. The test which we use for the estimation of bilirubin is known as the Vanderburgh test. Now the Vanderburgh test involves the combination of serum bilirubin with diazotized sulfanilic acid. This is otherwise known as the Ehrlich's diazo reagent. It is prepared by combining sulfanilic acid in HCl with sodium nitrite. So when bilirubin is reacted with this reagent, we find that isobilirubin is formed, which is red or purple in color. Now this gives, so when a reading is taken at 1 minute, it gives you the reading of direct bilirubin or conjugated bilirubin. To obtain the value for unconjugated bilirubin, you have to take a second reading at 30 minutes by adding an activator or accelerator like methyl alcohol. The reading is taken at an absorbance of 600 nanometers. If the serum contains both unconjugated and conjugated bilirubin in high concentration, the purple color is produced immediately. That is direct positive, and it is further intensified by the addition of alcohol to get the indirect positive. This type of reaction is known as a biphasic reaction. Now, what is the utility of estimation of bilirubin? Bilirubin helps us to differentiate the different types of jaundice. Now, as I told you, when plasma bilirubin is less than 1 milligram per deciliter, it is seen in case of normal individuals. But if the bilirubin levels increase more than 1 milligram per deciliter, it is known as hyperbilirubinemia. And if the bilirubin levels increase between 1 to 2 milligram per deciliter, it is known as latent jaundice. When the bilirubin levels exceeds greater than 2 milligram per deciliter, it diffuses into the tissues and produces a yellowish discoloration of the sclera, the conjunctiva, skin and mucous membrane, resulting in jaundice. Icterus is the term used in the Greek language for jaundice. So estimation of bilirubin is very useful for the differential diagnosis of jaundice. Now, in the case of hemolytic jaundice, we see that unconjugated bilirubin is increased and the Vanderburgh test becomes indirect positive. In case of obstructive jaundice, the conjugated bilirubin is increased and the Vanderburgh test becomes direct positive. And in case of hepatic jaundice, both conjugated and unconjugated bilirubin is increased, and this is known as Vanderburgh test biphasic. Now, in addition to the blood, the bilirubin in urine can also be assessed. Now, in a normal individual, bilirubin is not normally excreted in urine. Conjugated bilirubin is soluble in water and is excreted in patients having obstructive jaundice or hepatic jaundice. The lab test, as you have already done, is known as the Foucher's test or the Foucher's test. In case of hemolytic jaundice, unconjugated bilirubin is increased in blood and does not appear in the urine. The urobilinogen levels depends on the amount of bilirubin which is entering the intestine. In the normal urine, only trace amounts of urobilinogen are seen. In case of hemolytic jaundice, there is increased urobilinogen due to excessive production of bilirubin. Whereas in hepatic jaundice, the urobilinogen levels may be normal or decreased. In case of obstructive jaundice, due to the complete biliary obstruction, no urobilinogen will enter the intestine and will not be positive. Now, there is other tests which are used for assessing the excretory function of the liver, because in addition to bilirubin, the liver also is able to excrete out dyes and drugs. So, we do a dye to excretion test to assess the removal of dyes by the liver. This test is known as the bromosulfothioline test. In this case, 5% or 5 mg per kg body weight of BSP is injected intravenously. The sample of blood is tested 45 minutes later to get an estimate of the percentage of injected dye. In the normal case, the retention of dye is less than 5%, whereas in liver dysfunction, the BSP retention is increased. Now let's look at the test based on detoxification function. The two tests which we use to assess detoxification function is the hippuric acid test and the determination of blood urea. Now, in the hippuric acid test, we assess the detoxification function of the liver. In this case, we try to see how it detoxifies benzoic acid by conjugation with glycine to produce hippuric acid. The dose of sodium benzoate may be given orally or intravenously. So 6 grams of sodium benzoate in 250 ml water is given by the oral route, and the urine is collected in the next 4 hours. The amount of hippuric acid excreted in this 4-hour collection of urine is then measured. If the person is normal, we find that about 3 to 3.5 grams of hippuric acid would be excreted. In hemolytic jaundice, it is normal, whereas in hepatic jaundice, obstructive jaundice, liver cirrhosis, or any hepatocellular tumors, the excretion of hippuric acid is decreased. Another parameter we use for assessing the detoxification function of blood ammonia is the blood ammonia levels. As you know, the liver detoxifies ammonia to form urea, and this is impaired in liver disease. The normal blood ammonia levels is between 40 to 70 mg per deciliter, but is highly elevated in case of hepatitis and cirrhosis. Now, the next group of tests that we can use is to assess the synthetic function of the liver. Now, the liver is the site of synthesis of plasma proteins like albumin and globulin, except gamma globulins, and the blood clotting factors like prothrombin, factors 5, 7, 9, and 10. The synthesis of these can be affected if there is any type of liver dysfunction. Now, this slide gives the normal levels of the total proteins, which is between 6 to 8 gram per deciliter, albumin 3.5 to 5.5 grams per deciliter, globulins between 2 to 3.5 grams per liter. The albumin globulin ratio is also given 1.2 to 2.5:1. Now, a decrease in the albumin levels or hypoalbuminemia indicates hepatocellular disease like liver cirrhosis. An increase in the globulin levels or hyperglobulinemia indicates cirrhosis or infectious hepatitis. If there is a reversal of the AG ratios, that indicates advanced liver disease. Now, this could be due to decreased albumin levels and increased gamma globulin levels, because the gamma globulins are not synthesized by the liver but by the reticular endothelial system. Next, we use the prothrombin time for assessment of the synthesis of clotting factors. If there is a dysfunction of the liver, then you find that there is a prolonged clotting time. Now, as you know, vitamin K is also required for the synthesis of clotting factors, and vitamin K deficiency can cause an increase in the prothrombin time. So, first the vitamin K deficiency has to be ruled out, and the prothrombin time is determined before and after the administration of vitamin K to rule out any deficiency of vitamin K. In liver disease, we find that the prothrombin time is prolonged even after the administration of vitamin K. The next group of tests assesses the metabolic function of the liver. Now we see for assessment of carbohydrate metabolism, we can use the galactose tolerance test, because the conversion of galactose to glucose occurs exclusively in the liver. And if there is any liver damage, we find that this is affected. So for this, we administer 40 grams of galactose dissolved in water, and we find that in the normal liver, up to 3 grams of galactose is excreted in a 5-hour urine collection, whereas this becomes increased to greater than 4 to 5 grams when there is any kind of liver dysfunction. Next, we look at the lipid metabolism. The liver, as you know, is involved in the synthesis, the esterification, and the excretion of cholesterol. The normal cholesterol level is between 150 to 200 milligram per deciliter, and the ratio of free to esterified cholesterol is also altered in liver diseases. In case of obstructive jaundice, we find that the blood cholesterol level is increased due to retention of cholesterol, which is normally excreted in the bile. In hepatic jaundice, on the other hand, it may be normal or depressed. The liver is also the site of synthesis for plasma proteins and amino acids. The amino acids are converted to ammonia and excreted as urea. As I told you before, the estimation of proteins and ammonia can be used to assess liver damage. Lastly, we come to a very important group of tests, which are the liver enzymes. Now, the liver cells contain several enzymes which are released into circulation when there is damage to the liver. But the enzymes which are commonly used in routine analysis includes the transaminases, that is the alanine transaminase and the aspartate transaminase, alkaline phosphatase. Now these three enzymes are very important for assessing liver dysfunction. Gamma glutamyl transferase is also a very important enzyme, and the last two enzymes, that is the lactate dehydrogenase and the 5' nucleotidase, is not used to that extent now. Now when we look at the transaminases, I have given you the normal range in this table. Now alanine transaminase is a more specific marker, whereas the aspartate transaminase is also increased in MI and also in certain diseases involving muscular tissue. Now in hepatic jaundice, both ALT and AST are increased, markedly increased, that is it becomes between 500 to 1500 international units per liter. A moderate increase is seen in obstructive jaundice, whereas in hemolytic jaundice it is not increased. Alkaline phosphatase, the normal range I have given you, 313 King Armstrong units. Alkaline phosphatase is a very important marker in obstructive jaundice. It is normally excreted in the bile and is regurgitated into blood when there is an obstruction. Gamma GT, normal range is between 10 to 50 international units per ml and is used for the differential diagnosis of alcoholic liver cirrhosis. In the last slide, I am giving you the lab investigations of jaundice. This is used to differentiate the different types of jaundice, that is the hemolytic, the hepatocellular and obstructive jaundice. So starting with unconjugated bilirubin, which is increased in prehepatic or hemolytic jaundice but normal in hepatocellular and posthepatic jaundice. Conjugated bilirubin, normal in prehepatic jaundice, increased in hepatocellular jaundice and also would be increased in posthepatic jaundice. AST or ALT, which is normal in prehepatic jaundice, markedly increased in hepatocellular jaundice but normal in posthepatic jaundice. Alkaline phosphatase, normal in prehepatic and hepatic jaundice but markedly increased in posthepatic or obstructive jaundice. When we look at the urine parameters, urine bilirubin is absent in prehepatic jaundice but is present in hepatic jaundice and increased in posthepatic jaundice. Urobilinogen is increased in prehepatic jaundice, is present in hepatocellular jaundice but is absent in obstructive jaundice. The important questions that you can get related to this topic, you can get the liver function test as such, you can get the liver enzymes as markers for assessing liver dysfunction. Then you can get a question on the Vanderburgh test, and you can also get the lab investigations which we can do for differentiating the different types of jaundice. So please read with the help of these slides, and we'll be sending you the assignments shortly. Thank you.